So to start with, I know you've had some personal experience of suffering from Achilles tendinopathy. How do you find that that's helped you with treating patients and developing new treatments?
Yeah, that actually started all our research around the Achilles. And that was when I moved up here in 1993, something like that. I was running a lot and I started to get mid-porch and Achilles tendinopathy. And at that time I was the one who treated those patients, and we did that surgically. When rest and the NSAIDs didn't help, then we operated these patients and we cut out the thick part of the tendon and put them in a cast afterwards, and it was about 4 to 6 months before they could go back running. The results were not always good, and it was very difficult to get back to the same running level. Well, anyhow, I got this condition myself and I couldn't operate on myself, so I asked my boss, and he said, you know, it's only me and you working here, so I cannot afford to have you on sick leave after I have operated your Achilles, so there will be no operation. So I was quite irritated, and I went to the physios, and they helped me to organize rehab training, and we started to discuss maybe to try eccentric training. That was a new concept. There was no patient material, no study on it, but there were theories about eccentrics. So I tried that, and I became worse. My tendon was more painful.
Right.
So I went back to my boss, limped into my boss after a couple of weeks, and he looked at me and he said, if it's about an Achilles operation, you can leave the room immediately. So I was really angry, and then I went to my physio friends and I told them, now I'm going to load with eccentrics until I rupture the tendon, because then my boss needs to operate on me. So I loaded more heavy weights, and the more I loaded, the better the tendon became. So after a couple of weeks, something around 3 weeks, I was completely pain-free.
Wow.
Could go back running, and then we thought this must be only a one-case scenario and a coincidence. But we thought it was interesting enough to try this on our waiting list. My waiting list, I had around 20 patients with mid-porch and tendinopathy that I was going to operate on. And 15 out of those 20 were positive to try it, and all 15 were cured.
Wow, that's good.
After 1 year, one patient came back and needed to be operated, but the other 14 were cured. So that started new thinking around tendinopathy. This was completely against the thinking around tendinopathy, where you were supposed to do non-painful exercises, and now this was completely opposite. So that started it all.
I heard about eccentric training, and I heard your name sort of many years ago, and I think that's how most physios have heard about you, through Alfredson's protocol for eccentric training.
Yeah.
It's really sort of directed your career since then, it seems.
Yeah, it did. It all started as a coincidence, and I think lots of research starts by coincidences. Now we of course use eccentrics on all chronic painful tendons. We try to design programs for different tendons suffering from tendinopathy, and of course you don't cure all tendons with eccentrics, but you cure quite a high proportion, and especially among non-actives and recreational athletes. The high-level athletes often need more, but it's always worth to try it. And I think also depends a little bit when you come into the treatment process. If you come in early with eccentrics, I think you have a pretty good chance to cure the pain.
So if you knew then what you know now, would you still have been wanting surgery, or do you think you would have just gone down the training route?
We did far too much surgery in that time before we knew about the good effects with the eccentrics. And it was also, there was a big lap. We didn't have science enough. We thought that these thick tendons, they were filled with nerves inside the tendons, and then when we started to look, we took out a couple of hundred biopsies from different parts of the Achilles mid-portion, and we learned that there are basically no, or at least very few nerves inside the tendon. The majority of these nerves are located outside the tendon, so that also shows that to go in and interfere inside the tendon is very rarely indicated.
Mm-hmm.
So that's another positive finding in relation to what we learned from eccentric training, that maybe stay away from the tendon inside.
Mm-hmm. And that led on to some of your later developments in your surgical practice.
Yeah, it did.
Yeah.
It did. We managed to find where the majority of nerves were located, and they are located in close relations to regions with high blood flow.
Yeah. And
that high blood flow you can localize with Doppler equipment. So if you find that region, your interference, whether it's surgically or by sclerosing injection, is guided by the finding of the high blood flow. So you aim for the blood vessels to find the nerves.
Mm-hmm.
And the results are quite good. And you can combine those methods with very short rehab, because you've never been inside the tendon is similarly strong, and then you can load it early. So there are many advantages, and it's all based on the results from eccentric training.
Yeah. So I've seen you do a few sclerosing injections since I've been out here. What indications do you see for sclerosing injections? When do you start to use those?
Yeah, we don't use them very much on the mid-portion anymore, because we know that it requires often 2 to 3 injections, and you need 6 to 8 weeks in between. So it's time consuming. And then we also know that quite many of these mid-portions, they also have a plantaris tendon involvement. So basically all with mid-portion tendinopathy we now treat with an ultrasound-guided scraping procedure.
Mm-hmm.
And quite often also plantaris tendon removal. But for the insertion we use sclerosing injections at least once. It's a little bit diagnostic also, because it's a local anesthetic together with the sclerosing effects. So you get a pretty good view whether this injection cure the pain immediately after the injection. Yeah. And then sometimes it's very individual, but some patients, they respond very good to this agent, so they have a pretty good pain relief. And for those ones we continue and give them maybe a couple of injections more to try to cure the condition.
Mm-hmm.
But for the insertion it works roughly in around 50% of the patients.
It's pretty good.
But it's worth trying, because surgery in that region is quite major. You are out for 3 to 4 months after the procedure.
So the two sort of recent developments in recent years, I suppose, that I've sort of seen from your work have been the plantaris and then more recently the subcutaneous bursa, which we've seen quite a lot while I've been here. Yeah. Which is really exciting. So you were talking about the sclerosing injections for the subcutaneous bursa.
Yes.
I've seen you do that since I've been here.
Yeah.
It looks really hard. Very skilled. But so tell me about the subcutaneous bursa.
Yeah, that's another, you can say, coincidence that we found out about the importance of the bursa, because when you operate in the insertion, you most often have pathology in 3 different tissues. You have it in the subcutaneous bursa and the retrocranial bursa. Then you have tendinopathy in the distal tendon, and quite often you have bone pathology, whether it's a Haglund deformity or a sharp bone spur, medial or lateral side, or sometimes even central in the insertion. So it's very difficult to know where is the pain coming from. It could of course come from all these structures, these different tissues, but we have noticed that quite often most pain comes from the subcutaneous bursa. And we had a patient that she couldn't be away long periods for rehab because she had another disease, so she needed to be able to exercise every day. She had a severe lung disease. So even though she had massive bone pathology with sharp spurs, like bone bridges in the insertion, she was cured by only having the subcutaneous bursa removed. So it's something that's worth thinking about, that the subcutaneous bursa is the most nerve-rich tissue in that region, and it's probably always worth to first try to only take away the bursa, because then you can load immediately afterwards. It's a quite quick rehab.
Mm-hmm.
And there is no need for any intratendinous procedure that is time consuming for the patient. The rehab is long and also quite risky if you need to detach the tendon insertion. It's a risky procedure. So because of this one patient, we learn more about the subcutaneous bursa, and now I basically always in these patients with combined massive pathology, I always first test them by putting local anesthesia only in the subcutaneous bursa. And if they then can run around in here without pain, then I only remove the subcutaneous bursa. If they still have remaining pain after such an injection, then you need to think about also the other structures, the bone and the tendon. So we'll see in the future that we need to do some really good clinical studies evaluating this importance of the subcutaneous bursa.
But you've got some research on the nerve innervation in the bursa I've seen as well.
Yeah.
Which supports what you're doing already to an extent, isn't it? So
yeah, we did a study on patients having severe pathology in all these three different tissues. We took out both bursa, subcutaneous bursa and the retrocalcaneal bursa, upper calcaneus, and we did scraping on the deep side of the Achilles. And that was analyzed. And we found that by far most nerves we had in the subcutaneous bursa. That was 3-4 times. There were 3 to 4 times more nerves than in the second place. That was the retrocalcaneal bursa.
Mm-hmm.
So it's definitely nerve-rich. And if you study the literature, very little is mentioned about the subcutaneous bursa. Basically, all methods used today, they don't even touch the subcutaneous bursa. Quite often it's arthroscopical procedure, removing the retrocalcaneal bursa and parts of the upper calcaneus. Nothing is done to the subcutaneous bursa. And that could be a reason to why the results after surgery and insertion are varying and quite often poor.
Mm-hmm. Always good when we can be less invasive as well.
Yes.
Better rehab times and all the rest of the things you mentioned.
Yeah.
Seems a lot of your techniques have become a bit sort of more refined as you've found out more about the structures you're operating on in terms of innovation.
Yeah.
And I suppose that brings us on to the plantaris tendon as well.
Yeah.
The techniques becoming more targeted.
Yeah. In the plantaris, we started, instead of doing the polydoconal injection, the sclerosing injection, we started to do a scraping procedure, like I said. But then we had a huge material of scrapings, but not all of them had a good result. There were around 10-15% that came back with remaining pain in the mid portion, and quite often on the medial side of the mid portion. And when we did this initial scraping, the technique was to go in from the lateral side. But now with these recurrences, we started to look from the medial side. And then we found plantaris tendons being located very close to the medial Achilles, and sometimes even inside the medial Achilles. And by removing that part of the plantaris on the medial side, maybe cutting out 5-6 centimeters, we could cure the pain.
That's great.
So then we started to realize that the plantaris was a factor in subgroups of patients with mid-portion tendinopathy. And Christoph Spang, my research student, he did a thesis on the plantaris, where he showed that in contrast to the Achilles, 2/3 of the plantaris tendons, they actually have sensory nerves inside the plantaris, together with tendinopathy, similar type of tendinopathy as we see in the Achilles. And in 2/3 of those tendinopathy tendons there was also nerves. However, the majority of nerves were located in the fat tissue in between the plantaris and the Achilles.
Mm-hmm.
Mainly sympathetic nerves, but also sensory nerves. So that was, you can say, also a coincidence. It's always good to follow up your poor results. The ones that didn't get well, those are the ones you learn from. So follow-ups, that's something you need to do.
One thing you also do, which I was really impressed by, is how you assess all of the patients before and afterwards with the Visa A questionnaire, and actually you've got a huge database with a list of patients, a really long list of patients that you've operated on. So you're very thorough in following people up and seeing the patients that get well and don't get well.
Yeah, I think that's the way you should do it if you wanna get so to say a feeling of what you are doing is right or wrong. You need to follow everyone, at least as many as you can, up closely. Sometimes it's difficult with high-level athletes from different countries, but you can try to find out whether they're back in the team or back running internationally and things like that. But to keep them in your database, then you can keep relatively good control.
It's a good scientific approach.
Yeah, I think that you should start with the first one, so you can sort of compare from the first to the 500, and so that's the way I like to do it.
Okay, so the time I've been here, we've seen in quite a few Achilles tendons remnants of corticosteroid injections, cortisone, and it just looks like it's unmetabolized in the tendon. And we've seen a few holes in tendons and partial ruptures associated with these injections. So do you feel there's ever a role for corticosteroid injections around the Achilles tendon? What are your feelings on it?
No, I have a very strong feeling about the negative side effects with cortisone. I can understand why it has been used, because it immediately gives a very good pain curing effect. But after 3-4 weeks, then again you start to have problems. And the side effects in tendons is that it causes necrosis. If you put it inside the tendon, there is necrosis inside the tendon. If you put it outside Achilles, still parts of this cortisone injection can be transported into the tendon and again cause necrosis inside. Then it also causes necrosis in the fat tissue outside the tendon where you injected it. So all kinds of problems. And I used to myself inject in the retrocranial bursa because I thought that was safe to do that under ultrasound guidance. But I've actually had 2 cases where the Achilles ruptured, so to say, on the wrong side, on the deep side, in relation to the bursa. So most likely cortisone had gone through the bursa into the tendon.
Right.
So cortisone, in my opinion, has no indication at all close to the Achilles, or at least not even I was close to say far away from the Achilles, but for Achilles tendon disorders, I think cortisone is not indicated.
And how do you feel we should be sort of managing, I suppose, Achilles and patella tendons? Do you see that there should be a pathway that we'd follow?
Yeah, I think so. I think we should first use first we need to establish a proper diagnosis, and many people say you can do that clinically, but you cannot really do that on all patients. Like the older population, it's very difficult to exclude a partial rupture if they have tendinopathy. I've seen so many with partial ruptures together with tendinopathy. So you need ultrasound to have a proper diagnosis. And then if there is only tendinopathy, then I think you should subject into a loading regimen. So far there is most science around eccentrics. So that would be my first pick, but of course you can try heavy slow, and you can try isometrics, maybe even if there are only few patients demonstrated with isometrics, but you can always try that. And then if there is a poor result from loading regimens, then I think you should start to discuss surgery.
Mm-hmm.
But ultrasound guided mini invasive surgery.
So how long would you recommend my physio colleagues to see patients for, after a proper diagnosis is in place?
3 months.
Before surgery is considered. 3 months.
3 months, yeah.
3 months.
Yeah.
And if there's no improvement by 3 months, start talking about something more invasive. Yeah.
Yeah,
Mm-hmm.
mini invasive.
Mini invasive
You can
procedure. Yeah.
Definitely for the Achilles mid portion. For the insertion, maybe wait a little bit longer. Eccentrics, it's a little bit more complicated. Make sure that you have a proper diagnosis. Maybe do these diagnostic injections with local anesthesia in the bursa.
Mm-hmm.
Maybe try sclerosing polydoconal once to see whether there is an effect of that, and then go for surgery next step. But mid portion, I would be active with surgery already after 3 months with loading.
So for my physiotherapy colleagues who are sometimes naturally more predisposed to take the conservative route, what would you say to them to reassure them of the fact that this is a mini invasive procedure? Because having spent a month here, I've seen what you do, and it is, it's as minimally invasive as you could possibly possibly do, really.
Yeah. Now I would just say that it's important to realize that this is surgery done outside the tendon, so it's nothing inside. So there is no interference with the internal structure in the tendon. It's similarly strong as it was before the procedure, and over time we have seen that if you do this interference in the right spot outside the tendon, the inside start to remodel. So there is likely high potential in the tissues on the deep side of the Achilles mid portion.
That's great. So 3 months of conservative loading based treatment, and then start considering referral to maybe your tendon clinic or
Mm-hmm. And I would also say don't use too much shockwave or laser treatments and treatments that not really have been proven in good scientific studies. I know that there are some studies out on shockwave, but for the Achilles mid portion, it's important to understand that the pathology is on the deep side of the tendon. So if you start to shoot shockwave from the superficial side, you can actually injure the only part of the tendon that's normal, the superficial side. So for the mid portion, shockwave is in my mind definitely not indicated.
Mm-hmm.
In insertion, it could be used for the subcutaneous bursa, because then the pathology is on the superficial side, so it's reachable. Before methods like that are being used, maybe think about where the pathology is localized.
Mm-hmm. Mm-hmm. So one extra question which we didn't mention is about PRP injections. So tell me what you think about PRP.
I'm a little bit frustrated about this, because inject PRP into a tendon is not based on any science at all. There is no study in the world that has shown that there is a need to inject anything in those tendinopathy tendons. There has been misunderstandings for many years that there is a partial rupture in the tendon, a hole in the tendon that needs to be filled out with something, but it's extremely rare to have a partial rupture in a tendinopathy tendon. So it's never indicated to put anything into that tendon, because there is no hole to fill out, there is nothing to heal. It's another type of condition. So to put PRP into a tendinopathy tendon is is absolutely not indicated. And stem cells, it's the same. Why should you inject stem cells? The biopsies have already shown that there are already multiple stem cells in these tendinopathy tendons. So why should you inject more? And you never know what you can induce. We know that some of these cells in tendinopathy, they have changed characters and start to produce pain substances. So they act more like pain-producing cells. So if you then inject PRP or stem cells, maybe you will act on these cells to become pain producers. So maybe you end up having a severely painful condition inside your tendon. But overall, there is no indication to inject anything into a tendinopathy tendon. There is no hole to fill out, nothing to heal. It's a different type of condition.
Okay, so no indication for PRP?
No, definitely not. You can injure the tendon if you inject, because then you create increased pressure where you inject this substance, and that can actually induce a partial rupture. So
pressure in the
so
necrosis.
in my mind, it's completely wrong thinking to inject PRP. It's not based on any science at all. But
So
it's again, when the industry promotes methods, we have a tendency to stop thinking, because the industry is pretty good in promoting, and then we stop thinking about nature and the normal capacity in different tissues, normal healing properties.
Yeah, we were at a meeting recently, weren't we? And there's a chap giving a presentation, and whenever there's a name of a company in the corner of every slide, I'm always a little bit suspicious. Who's actually promoting the treatment? The guy doing the presentation, or the guy paying the guy doing the presentation?
It's always I'm always amazed by this, how this acts upon us. If suddenly many companies promote certain kits to inject the substance, we have stopped thinking about why we inject the substance. We want to get the kit, but we don't think about why inject PRP in a tendon where there is no hole and nothing to heal. It's tendinopathy. Tendinopathy is based on other type of changes in the tissue. When a tendinopathy tendon can start to normalize after eccentric loading, then we should really start to think about healing properties in the tendon. So that's my opinion.
Excellent. Anything else you wanted to add? So we talked about PRP, corticosteroid injections. We've talked about obviously surgical procedures. Anything else? High volume injections? Anything that you wanted to talk about with any of that?
High volumes has become popular, and maybe you can try it, but without cortisone, of course. When we do the scraping procedures, we struggle to scrape loose the fat tissue that has basically sometimes invaded the deep side of the tendon. So in those cases, I doubt that fluid could release the fat, but maybe in early cases. But I know my colleague Lorenzo Maschi at Pure, he has tried it, and he has not had good effects from using it. So it's nothing that I use.
No. Okay. Well, thanks again.
Okay, thank you.